Alright, in this section we're going to talk about the axial skeleton. We're going to focus on the vertebral bodies and the role of the ligaments, and then we'll move into the kinetics and kinematics in the next section. Let's just talk about really how amazing the design is. Our bodies are really amazing in general, but if we look at the spine and we start to understand the roles of the curvature, we can start to understand that it's made for a lot of tensile forces that are put onto it, and we'll talk about those in a little bit. We just need to collectively understand that there's 33 vertebrae, there are 23 intervertebral discs. We'll understand that the discs, as we get into the sacrum and the coccygeal region, are not there, that those are fused portions of the spine. Our 5 regions typically include the cervical spine, the thoracic spine, the lumbar spine, and we have our sacrum and our coccyx. The curvatures are interesting. We can understand that as a fetus grows, that it's actually primary into a flexion type of scenario. And so we can understand that our primary curves are really those curves that stay in the position that they were when they were in the fetal position. So our thoracic and our sacral curves are considered primary curves. Our secondary curves start to develop as we start to move into an upright position, and those are really our kyphotic curves and our lordotic curves, understanding that the posterior convexity is described as our kyphosis curvatures, and then our anterior convexity are described as our lordotic curvatures. We can understand too that it's really made to take a significant amount of force. Kapanji just looked at the difference between our spinal column and the way in which the curves are compared to a straight rod, and with the curvatures we're able to take a tenfold type of axial compression versus a straight rod. Pretty amazing, don't you think? So let's just talk about the functions next. This is similar to what we know just even from anatomy, that our vertebral column has numerous functions, but we're going to categorize it into four main categories. So protection. We know that the vertebral column has bony protection around it. We also know that it has very strong ligaments. We understand that there's a lot of attachment sites into that section. So really understanding that it's there to protect. Secondary, it provides support, carries the weight of the body above and below the pelvis. And we will talk about this role a lot when we talk about core strength, that we want a stable spine in relationship to the extremities moving or the head moving, and understanding that this is very important in making sure that our bodies are healthy and able to carry the weight of our head and really control our limbs as well. It provides an access point. So it's that center point of our body, and we will gain more understanding that as we move in all different planes, that our access point is within that vertebral column. And then we know that it has roles in posture and movement, and that it's a key component to that. And a lot of our dysfunctions that we'll treat as physical therapists will stem within that spinal column. And does our spinal column allow appropriate movement? Do we have abnormalities such as scoliosis or a pathological kyphosis that's affecting the movement of our shoulders and creating pain that way? So multiple functions, but just understanding that those are the four main that we're going to focus on. Let's talk about a little bit the closed chain scenario. It's easy to see that we have a closed chain when we contact our foot with the ground, but it's also a closed chain environment for our head. A large in part, our body is made to function so that we can optimally align our sensory organs, meaning our eyes and our ears. Most of the time, our postural abnormalities will correct themselves within the spinal column to make sure that the eyes are righted to the environment. So if you start to look at people that do have scoliosis or maybe a leg length discrepancy, the body is accommodated for that. Maybe they stand with one leg farther out into the frontal plane, maybe that there's actually a change in their spinal column in the frontal plane as well, in which that their eyes are still righted to their environment. It's an interesting kind of phenomenon that when we start to switch the roles, so thoracic spine really should be for mobility, that we're going to see alterations where our cervical spine would try to become a more stable environment, or our lumbar spine would become a more stable environment. So just thinking about, we need a lot of stability and mobility throughout the body, and understanding how does that play into our role as a physical therapist, and looking at people's function and their design and how things are different. Okay, let's move on and let's just look at what that mobile segment is. So when we start to understand that the mobile segment is made up of the vertebral body, so this is the vertebral body right here, right? And that's a big weight-bearing structure of the body. It's made up of a shell of cortical bone, and then in the cavity is that cancellous bone. This is made in a great structure so that it can take on a significant amount of compressive forces. Then we start to get into the neural arch. So the neural arch is consisting of our pedicles and our posterior elements. So it starts about right here and then encompasses those posterior elements. The pedicles transmit tension and bending forces from that posterior element to the vertebral body. So very important in that transmission of forces, and can also be a source of fracture sites, a stress fracture. We'll talk a little bit about that in the next couple of slides. The laminae is centrally located and serves as the origination point for the rest of the elements. It's kind of that roof of the neural arch, and it sends some protection for the spinal column, so really an important part of that. It then transmits forces through the pars interarticularis, and this is where those bending forces are transmitted vertically, and they're orientated to the lamina and those horizontal pedicles. So we look at this and we start to gain understanding that the mobile segment is the two adjacent vertebrae, so this would be 1, this would be 2, and that we have an intervertebral disc right in the middle of that, and then we have all the soft tissue structures, so we have ligaments, and then we have all the muscle attachments into that as well. Let's talk a little bit just about a typical vertebrae. Into sections 3 and 4, we'll talk about just differences and regional differences in the cervical, thoracic, lumbar, and sacral elements. But if we look at this typical vertebrae, it's easy to see the big vertebral body right here. Whoops, let's go back to that. Let's touch our pen again. So the big vertebral body right here. And this is true, and this will change size given the relationship between the cervical spine, lumbar spine, and thoracic spine. And then we touched on the posterior elements are back into here with that neural arch. And we look at the articular pillars. So if we just dive in a little bit deeper, we can understand this is the inferior. I'm just getting good at this pen thing. So inferior articular pillar, and then we have our superior articular pillar right there, so superior. These are important attachment sites for above and below to the vertebral bodies above and below that. This section right here is the transverse process, and then this section right here is the spinous process. These are important for us, and we've already palpated those and understand that those play important functions in our role of how we can mobilize a joint and create more space within that joint. It's nice, these articular processes actually start to form a pillar, and also known as that articular pillar, in which their function is to perform or provide a supportive column, and we can see that in that sagittal plane orientation. So what happens, let's talk about that pars interarticularis a little bit. It's actually known as spondylosis, is a condition where that pars articularis becomes fractured. And this will become because typically of some type of stress fracture. It's a very common in gymnasts. And so with that repeated extension, most commonly occurs at L5, L4, L5, just due to the orientation of the way in which L5 is positioned. It starts to gain more stress, especially if we have more of a degree of curvature there. So this right here is your pars. Oh gosh, well, I'll get this pen thing. So this is really our pars. So we can look at that. That's in a normal functioning there. And then right here we start to see that there's a fracture of the pars. Well, this starts to become very important because this actually helps hold the vertebrae in place. And so what we can start to come to understand is that if we have a fracture of the pars, that we can also get slippage after that pars articularis has maybe had some type of fracture. So we would call this a spondylolisthesis. So right in here, we have the pars articularis fracture, but then this vertebrae right here starts to slip forward. This can cause tension onto the spinal cord and can cause some pain not only in the back but probably down into the leg, and we understand that through that sciatic distribution and compression onto the sciatic nerve or the elements in that section. What happens is those posterior elements get completely separated from that neural arch in the vertebral body, and that body slips forward. L5, S1 segment is the most mobile due to that and has the most shearing, so like we talked about before. This can actually lead to hypermobility, and that is it can feel very unsafe for a lot of your patients, and they won't like extension activities. They'll typically be fine with flexion-based activities. Just a little case studies there. So let's talk about that intervertebral disc. Let's move on a little bit. And the function of that intervertebral disc. So I just thought this is a good correlation because you have small discs, which are in your cervical spine, and you have large discs in your lumbar spine. And our role of our discs is to increase motion and to also transmit load from one vertebral body to the next. The size matters, and it helps relate to the amount of magnitude that the transmission of forces can happen. So smaller in the cervical spine, so 3 millimeters, larger up to 9 millimeters in the lumbar spine. The greater the ratio between the disc and the vertebral body leads to greater mobility. So cervical spine needs a lot of mobility, and so it has the greatest ratio of disc to vertebral height. And then it's actually the smallest in the thoracic spine, which we understand that thoracic spine really has a lot of stability, especially due to the rib attachments. So here we just see a little bit greater detail of the intervertebral disc. This is review from anatomy, understanding that the annulus fibrosus in here and the nucleus pulposus. So that nucleus pulposus is a hydrofluid-filled disc, and that this annulus fibrosus is very thick and keeps that nucleus pulposus in line. When we start to have some dysfunction, we can start to see the nucleus pulposus and the annulus fibrosus after you actually push out onto the spinal cord. The greater degree of injury, that nucleus pulposus and the annulus fibrosus will actually tear, and you'll see some leakage down into the spinal column. It's a pretty significant injury and definitely will require surgery at that point. Other than that, the earlier stages of that disc, sometimes can be painful and sometimes not. It's actually a big debate right now that imaging actually does not correlate to the degree of dysfunction that is seen in a patient. And so pain science is a hot topic, and understanding that there's a lot of emotional components that go into it and a lot of soft tissue components that go into it as well. So this is just actually one of our friends, and he is a big jiu-jitsu. He got second in the Grand Canyon State Games recently, and he's having bilateral numbness and tingling into his arms. And right here you can see that in his cervical spine we see the nice border of the spinal cord here. But as you see, this is actually the disc that is now pushing out into the vertebral column, and could be possibly that contributing factor to his numbness and tingling. As we talk a little bit more about the ligaments and the stabilizing factors around the spinal cord, we can know that, yes, this intervertebral disc might be pushing out into that, but that changes the role and the way in which the ligaments function as well. So, yeah, he has imaging that correlates with some of his symptoms, but remember, as a physical therapist, we're always going to treat the whole body, and we're not necessarily treating this disc pathology, but we're treating the symptoms and the impairments that we see. So articulations, just a little tidbit. There's my family. We were in Portland and got to be on the beautiful water there. The cartilaginous joints and the diarthrodial joints. So the cartilaginous joints being the intervertebral discs and their relationship to the intervertebral or the vertebral body, and then the diarthrodial joints. So those would be the Zygapophyseal joints between the vertebral bodies. Also, don't forget the diarthrodial joints connecting with the skull and with the pelvis as well. So this is, I love this this picture because it really shows the great way in which our interbody joints move. So we see that there's tilting and that there's rocking occurring. We understand that there's sliding in the anterior posterior direction and into the medial lateral direction, and there's also torsion that occurs. It's cool to see that the tilt can happen in the anterior and posterior direction, and also in the lateral direction. So we look at that also combos happen with slide, tilt, compression, and distraction, leading us to that there's actually 6 degrees of freedom that can occur into the interbody joints. So into the ligaments, let's just understand and review the ligaments. Go through, take a little bit of time, and refresh your memory on where the ALL, the PLL, the ligamentum flavum, the interspinous ligament, and the supraspinous ligament are. And if you're having a hard time, just always orientate yourself to where the vertebral body is and where the neural arch and the posterior elements are. This will always help you in that. And then understanding the ALL and the PLL and what they resist can often help you as well in going through that. So make sure you take some time, pause, just review your anatomy, and come back to that. Let's just dive into the ALL and the PLL. And these pictures are phenomenal because they show you how that in the ALL, in flexion, that ALL is compressed. And that when we go into extension, that ALL is very taut and tight, and it's made to restrict that. Another thing to remember with the ALL is it connects with the annulus fibrosus, and it reinforces that anterior lateral portion of the intervertebral discs. So in our case of our friend, our jiu-jitsu friend who has maybe some pathology into that disc area, now we're going to know that there's also some connection with that anterior longitudinal ligament as well, and that possibly that stability that we need is not quite there. So we're going to need to retrain a lot of stability in our patients that are having some issues, maybe that we would categorize them with with possible disc issues. The PLL is much thinner than the ALL. ALL is very thick, provides a lot of stability, although in the thoracic spine it's a little bit different, right? So the PLL is a much thinner ligament. It spans just like the ALL, has superficial and deep layers. Interesting though is as the PLL moves into the lumbar spine, it becomes very thin, and we can think that maybe this might happen with creep over time, because in flexion that ligament is getting stretched, and that poor posture leading to creep of all those structures within there. And possibly there might be a relationship between that. Now we have more movement of the lumbar spine than we want, and there's creep happening due to postural considerations, and possibly that the intervertebral disc doesn't have as much support secondary to that PLL. So the ligamentum flavum, I just love that word. It's kind of a cool word. It's really a phenomenal type of area in our body because it's highly elastic in nature, and it's a great support structure for our intervertebral disc because it creates that continuous compression. It's one of the areas of our body that actually even in a neutral position is still on tension. It doesn't buckle in on itself, and so it's a pretty amazing structure. It is creating that continuous compression of the intervertebral discs by creating a pressure that remains very high, and secondary to having high advantageous structure because of that elasticity in and of itself. It's a connective tissue that links to links those intervertebral vertebrae together. It connects those inside of the vertebral structures posterior to that central canal. It's really the rear border of that central spinal canal, and that thickening of that ligament will decrease that available space of the rear of the canal. It's really not a problem, but it can become a problem if there's congenital conditions or a developing condition, maybe some spinal stenosis or back injury where there's narrowing occurring, and now the combination of the narrowing and that compression can elicit maybe some issues elsewhere in the spine. This is really just for your guys' review. Please use your text to go through and fill this out, and come prepared to discuss this and understand the function and the region of what these different smaller ligaments are. But even though they're smaller, they're still very important into the roles of our spine and that stability of our spine. So understanding that, for an example, the supraspinous and interspinous during hyperflexion are the first to fail. So what does that mean for us, and really gaining some understanding into that. Okay guys, so I really want you to just make sure you understand the typical vertebrae, understand the anatomy of the intervertebral disc and the roles, explain and identify the ligaments of the spine and their function, and then just get ready for that kinetics and kinematics lecture coming up.